that, I'd like to start by introducing Dr. Adam Gaffney. And as we do, and as Adam has done for the last few years, we're going to ground ourselves in the facts. And that's crucial, right? Because this is one of the most important roles that PNHP has served over the years. We are a source of the facts about our healthcare system. And getting this data update is what gives you the tools to talk about it. This is going to help you build your slide decks for your single-payer 101s, for the ground rounds, for the discussions that you're going to have in the upcoming year. You're going to want to know what the current research, what the current literature says relative to our healthcare system and why we need a single-payer system so badly. So Dr. Gaffney is a past president of PNHP and an assistant professor of medicine at Harvard Medical School. He's also, like me, he's an ICU doc and pulmonologist at the Cambridge Health Alliance. He has authored or co-authored more than 60 journal articles with first authored publications in journals like Lancet, Annals of Internal Medicine, British Medical Journal, JAMA. So he's also the author of a book, To Heal Humankind, The Right to Health in Human History. Adam is a good friend of mine, and I am really happy to welcome him to the stage for our health policy update. Adam.
Okay, good morning, everyone. It is so good to be here. This is truly one of my favorite times of the year, and I wish that we were in a different political situation. I wish our nation wasn't plunging into a scary period. But as Phil said, we know how to fight what is coming, and we need to fight for something even better. And that's going to be our task today. And what I want to do in the next 45 minutes is give really some updates, fairly selective, because there's obviously a lot out there, about what's happened this last year in the literature, and what are the key points of data and evidence and injustices that we're seeing come at us, both old and new. So without further ado, I'll get started. This is going to be fairly dense, as is the tradition of the data update. So buckle up. Okay, so let's just get started with a brief note on where we stand in terms of health as a country. So, decades of improving life expectancy came to a halt, not during COVID, but before COVID. In the decade before, life expectancy gains leveled out, even fell some years, and then, of course, plunged with the COVID pandemic. As we recover, we are going to see life expectancy rebound, but we're still going to be dealing with the fact that U.S. health, the health of Americans, was faltering even before the pandemic. Now, what this figure does not show is the divides among Americans. If we look at black and white Americans, for instance, just to use one example, a startling divide in life expectancy that persists today and that worsened during the COVID pandemic. If we look by class differential as well, we see striking divides in life expectancy that are actually worsening. Obviously, there's many factors that go into this, so we're not going to be able to talk about that all now. But I do think that healthcare is one component. What is the evidence for that assertion? Well, here's another recent paper looking at control of hypertension among people with hypertension, right? This is a key thing that modern medicine does that we know prevents strokes, prevents heart attacks, prevents death. And we can see the highest income group in blue, their hypertension control, about half, which isn't even that good, about half have their hypertension controlled. And then among lower income folks, hypertension control is worsening. So that's on us, right? The medical profession. We've seen a tenfold rise in cases of congenital syphilis over the past decade. Again, totally preventable with medicine, totally preventable with healthcare. This is a sign something is wrong. So really, even with the COVID-19 pandemic receding, U.S. health is faltering, particularly among younger adults. Urgent action is necessary. All right. Let's move on to coverage and access to care. So I always present an updated version of this figure, just showing uninsurance rates in the U.S. going back to 1963 before Medicare and Medicaid. Obviously, those programs made a big difference, as pretty obvious from the figure. Things got worse during the Reagan administration as Medicaid was cut and unions were under attack. Things got better with the Affordable Care Act. Things surprisingly got better during the COVID pandemic. We didn't expect this. Why did that happen? Well, because people were allowed to stay in Medicaid. As a result of emergency pandemic legislation, the Medicaid continuous coverage provision actually kept because usually in a given year, people are constantly losing Medicaid, even when they still actually are eligible for it because they don't jump through the right hoops or fill out the right paperwork. So when that happened, things got better. But that still left us with about 7% on insurance. So again, that Medicaid continuous coverage provision is now ending, as you're probably aware. So what's been referred to as the Medicaid unwinding has begun. Enrollment fell from 95 million in April 2023 to 80 million, about 15 million less, in July 2024. This is predicted and projected to produce a 6 million person increase in the number of people without health insurance in this country. Because of people's confusion about their own status and whether or not they're actually enrolled in Medicaid, many of those folks already believe they're uninsured. So we may not see that full number in the national figures, but it doesn't make a difference because it's there, it's real. And the CBO is projecting that the number of uninsured will rise in the coming years as a result of this to 32 million by 2027. So we are going to be moving further, not closer, to universal coverage in this country under status quo conditions, not even getting to, which I will, what the Trump administration might be sending down the road at us. All right, obviously we know coverage is not the end-all be-all of adequate access to health care. Let's talk deductibles. 2024, deductibles, family plans, employer-sponsored insurance. This is generally thought of as the most generous form of private insurance. Family deductibles range from nearly $3,000 to nearly $5,000, depending upon the type of plan you're in. Let's have a look at the Affordable Care Act Marketplace Plan average deductibles for 2024. You may be aware they're divided into metal tiers. Gold is the highest premiums, bronze is the cheapest monthly payments. But because of that, if you have a bronze plan, your annual deductible is about $7,000. There are subsidies available to lower income families, but even for very working class families, say a family of 4 making $65,000 for the whole family, they're still going to be in that $4,500 deductible on the far right for that coverage. And that's unaffordable for a working class family. And it means, we know what it means. It means that people go without needed care, or if they get it, they wind up in debt. And, I think as doctors, we've always known this. Our patients have always known it. It took the health economists a little while to catch up and realize this was happening after arguing for, since the 1970s that we needed skin in the game to save American medicine from out-of-control healthcare costs. They've come to realize that actually it's killing people, these kinds of cost barriers. This was a recent study that looked at people who were moved into a high-deductible healthcare plan who had diabetes, and the impact relative compared to a control group, it's a quasi-experimental study, the impact on vascular complications, finding an 11% increase in the odds of a myocardial infarction, a 15% increase in the odds of a stroke, a 123% increase in the odds of a lower extremity complication. I think that's supposed to be amputation, actually. So the fact is this is doing harm to our patients. And the health economists now are aware of that, but it's unfortunate that it's taken so long because we've built a healthcare system around the idea that you need skin in the game to keep costs down. And that's obviously failed both economically and in terms of health outcomes. If you just look globally, this is an update of what I've shown in the past. Overall barriers to care. The blue line is people who said they went without needed medical care in the last year due to cost. Yeah, things got better. From the height of the Great Recession, but they remain bad. And about 15% of Americans go without needed care every year due to cost, whether that's prescription drugs, doctor visits, whatever. So this remains a major problem. Consequences of these barriers are not just health, they're also obviously financial. A recent study looked at medical debt postpartum. And found that, if you look at people, postpartum women with private insurance, for example, 12% had medical debt in collection since childbirth, and 26% still owed money for that childbirth cost. Those childbirth costs 12 months postpartum. That's just for the cost of the actual delivery care. The reality is that the problems and the illnesses of one family member affect other people in that same family. This is a study from our research group led by my colleague Lenore Azaroff, and it looked at how parents get locked into jobs because of concerns that their child might lose health coverage. So overall, about 7% of parents say they avoid changing jobs because they were afraid that it might compromise their kids' insurance. But we looked at parents of kids without cystic fibrosis, obviously a very serious pediatric illness, and parents of children with cystic fibrosis. And among those parents of kids with cystic fibrosis, nearly 1 in 5 said they stayed in the job because they were worried about their child's health insurance. That's like, I mean, how difficult must it be to have a child with such a significant illness and to compound that with these sort of worries and these sort of constraints? It's kind of unconscionable. So to summarize, yes, uninsurance rates right now are at historic low levels, but we remain very far from true universal health care, which I would define as single-tier, seamless care without financial barriers over the course of the lifespan for everyone, which is what Medicare for All would do. All right, let's get into, and that's what we're fighting for. Let's get into a somewhat more wonky, but very important topic, and that PNHP has been focusing a lot on recently, Medicare Advantage. Very briefly, these are private health insurance plans that take basically taxpayer dollars to provide private coverage to Medicare beneficiaries. And as you're probably aware, Medicare Advantage is taking over Medicare. The modern version of the program was only started around 2003, and in 2007, you can see less than 1 in 5 Medicare beneficiaries had Medicare Advantage. The remainder were in the traditional fully public program. That share has risen to 54% in 2024 and is projected to rise to about 2/3 of Medicare beneficiaries over the coming decade. And who knows, this may be optimistic. We know that these plans are vastly, grossly overpaid by taxpayers for the care they provide to seniors. And MedPAC, which is the nonpartisan congressional advisory body on Medicare, recently calculated overpayments to Medicare, which come from two main things, which I'll get into. And their calculation is that over 2007 to 2024, we overpaid these big insurance companies by more than $500 billion. Now, what I've shown here on this slide is not just the overpayments, but the administrative spending of Medicare Advantage. So Medicare Advantage is vastly more inefficient than the traditional program, with overhead, the amount that they take that doesn't go for care, but that they retain for their processes and profits and management and so forth, well above 10% compared to 2% in the traditional program. Anyway, if you add up all of that administrative spending over that period, as we do here, you'll see it's almost the same. So really, all those overpayments are being retained by these insurers for their internal business processes and profits and salaries. Okay, so what's driving these overpayments? Not going to focus on this too long, but two things. One is coding intensity. This is why, as doctors, we're so incentivized to code fully. And second, favorable selection. Kicking out sicker people, trying to pull in the more healthy ones, right? Those are the two tactics. For coding intensity, one way Medicare Advantage firms do this is by having in-home risk assessments by nurses. Now that sounds nice. A nurse comes and visits you in your home. That's something that sounds good. But they're not doing it to provide care. They're doing it just to get more diagnostic codes on your medical record that will then drive higher capitated payments from Medicare. So, for instance, this recent study found that these in-home health risk assessments, along with chart reviews by Medicare Advantage firms, increased risk scores, which is what determines payments, by 6.6% in 2016, by 7.4% in 2021, which translates to between $3 and $15 billion overpayments just for this tool, just for this tactic. Despite these greater use of in-home risk assessments, Medicare Advantage enrollees get less actual care. So they get, for instance, 4.9% fewer nursing visits at home, 2.7% fewer physical therapy visits, 5.0% fewer speech therapy visits. So it's less care at higher cost. Medicare Advantage firms, advertise heavily, and that's one of the reasons why they've been able to increase their share of the market. They also do offer, some extra benefits. For instance, dental care. But recent literature is suggesting that these extra benefits aren't really adding up to much. This recent study, for instance, looked at actual dental expenditures, dental care received in Medicare Advantage MA and traditional Medicare TM, and you can see there's really no difference. So for a variety of reasons, these extra benefits are not necessarily translating into a substantive difference in terms of actual care received. I want to close on one last point. We spend a lot of time when we talk about Medicare Advantage focusing on how they're overpaid and how the care isn't, and how people get less care, and those are absolutely true. But what recent literature is also suggesting is that Medicare Advantage is undermining a core original principle of Medicare, which was the idea, if not always achieved, but at least the idea that everyone in the program kind of has access to the same level of care, the same doctors, the same hospitals, basically all the doctors and all the hospitals. Medicare Advantage firms are increasingly disproportionately enroll lower income and minority individuals who understandably are attracted in many cases to the fact that these plans, because of these overpayments, are able to offer, for instance, zero premium for the drug plan, right? Makes sense, you're strapped for cash. But what does this mean? It means we're actually moving towards a more fragmented, more segregated system, even within Medicare itself. And those equity implications haven't received adequate attention. So again, Medicare Advantage does not only waste money, its business model is premised on care denial, and it's undermining the idea of equitable single-tier care for the elderly. I'm going to go into an even more wonky topic, supply of care and capital. So you're going to hear a lot, particularly from the right, about supply-side solutions to healthcare. We need more doctors, more hospitals. And that can sound attractive, but the truth is a little more complicated. Let's start with doctors. Do we have fewer doctors? Well, yes, we have far fewer primary care doctors per capita than other countries, like 1/4 the number of primary care doctors compared to France. That's a problem. But if you look at specialists, we're actually mid to high. We actually have more specialists than a lot of high-income countries. For some reason, Germany has the most. I don't really know why, but they're kind of the outlier there. All right, you put them aside, and we're pretty rich in specialist supply. So we got enough of people like me and Phil, okay, generally speaking. We may not be in the right places. We might not always be working in the places that need us the most, but there are enough of us. There's not enough of the primary care physicians. So increasing the number of specialists is not the answer to the problems of U.S. healthcare. The lack of primary care doctors obviously has significant health impacts. I just thought a study that really spoke to this issue. It looked at areas with very mild PCP deficiencies, enough doctors, that's the dark blue, and the light blue is areas with severe primary care doctor deficiency, shortages. And what happens is in those areas without primary care doctors, surgical procedures which should be performed electively, like AAA repair, colectomy for cancer, incisional hernia repair, are more likely to be performed emergently with more complications. And that makes sense intuitively, but the data supports that that's what's happening. Let's talk about hospitals. I mean, do we need more hospitals? Well, yes, but we need them sometimes we often don't have them in the right places. We have a market-driven system that determines where healthcare is where it is and where it dies. So, for instance, this study found that Black communities had more than a 4-fold higher odds of losing a hospital between 2007 and 2018. We did a recent study looking at total hospital capital assets. These are physical assets, the buildings, the real estate, the equipment, in a region, and looked at it, how does it correlate with communities' health needs and how does it correlate with their income? And it turns out, maybe not surprisingly, richer communities are healthier and have more healthcare and hospital infrastructure. Poorer, sicker communities have less, which is the opposite of what it should be in a rational system. So This is something that healthcare reform needs to address. It is something that Medicare for All would address by having separately planned and allocated capital expenditures, distinct from operating expenditures. But the point is that healthcare capital should be allocated on the basis of community needs, not wealth. And if you do what we're doing now, which is market allocation, you produce what Julian Tudor Hart referred to as the inverse care law. Places that need the care the most have the least of it, and vice versa. Okay, let's turn to for-profit care, and I want to begin by saying something about what's been playing out in Massachusetts, but is national news that some of you may have heard of, which is the complete fiasco of the Steward healthcare system that really resulted in the looting of Massachusetts hospitals. So a quick timeline for those who are unfamiliar. In 2010, and the reason why I'm focusing on this is because it speaks to a much broader phenomenon. This is not just a local story. In 2010, the Boston Archdiocese sold off its nonprofit Catholic hospitals to Cerebras, a for-profit private equity healthcare firm. And the long and short of it is, within 6 years, they sell off all of their actual hospital real estate to one of these firms. That generates $1.2 billion payoff. That allows them to give almost $500 million to their investors and saddles those hospitals with unaffordable lease payments. In the coming years, they grow. They ultimately, Cerebras doesn't want in and sells off this hospital chain to these new physician owners. Again, they make $800 million off the system at this point. These new owners get $111 million in dividends. The new CEO, as I'll get to, buys a $40 million yacht. Meanwhile, these hospitals are spiraling. The care is deteriorating. Bills are going unpaid. There's equipment shortages. There's scandals in terms of health outcomes. There's understaffing, all the bad stuff. This year, they file for bankruptcy. Lots of unpaid workers. Two of their hospitals in Massachusetts, one of which is in a minority area, closes. The state is on the hook for nearly $500 million in bailout to keep the other hospitals going. And while this is all happening, the CEO takes his $40 million yacht to the Galapagos Islands. So, I don't know. It just kind of says a lot, I think. I feel a little maybe hypocritical putting this up because I did myself go to the Galapagos last month, but I did not take PNHP's private yacht or planes. So you can ask Phil. So, okay, this is not just a local story. This is a study from our research group led by Elizabeth Schreier looking at hospital capital assets before and after PE acquisition. You can see the orange line is private equity owned acquired hospitals, and capital assets plummet. They're stripping assets, they're strip mining, and they're profiting in the short term and then undermining care in the long term. It's not a complicated story. This isn't just about dollars and cents. It's about patients' health. After private equity acquisition, hospitals see a 25% increase in hospital-acquired conditions, a 27% increase in falls, a 38% increase in central venous line-associated infections, presumably the consequence of cuts in staffing and worsening quality of care. This is not just in hospitals. I'm just going to run through the latest stats for other areas of healthcare. In the last decade, PE acquired 41 cardiology practices. They roll up these practices into bigger and bigger entities before selling them off to the next private equity group, about a 600% increase in practice sites. PE acquired nearly 3,000 behavioral health facilities, nearly 7% of all facilities all over the country in the last decade. Hospices, originally started as these nonprofit, religious-oriented sometimes, end-of-life focused care. And what's happened is it's turned into a giant corporate industry. 124 hospices taken over by 47 PE firms from 2015 to 2022. And it's not enough to fight PE. We need to think more broadly about who should own our healthcare facilities. And I would argue that communities and the public, and not the privateers and profiteers as well, and corporations should be the owners of our vital healthcare infrastructure. A word on administrative waste. This is an important one when it comes to thinking about what kind of healthcare reform we need. American healthcare is getting increasingly inefficient in terms of the administrative overhead. The orange line shows the percent of total health spending going toward administration for private health insurance. It's risen to nearly 7%. And if you look at the total administrative spend, we're at about $334 billion in 2022. And much of that, the majority of that, would be eliminated under single-payer healthcare reform, generating the savings you need to actually fund the stuff that does help patients. And we know this kind of reform can work just even with a model that's close to home, the VA. In the VA, about 29% of the workforce focuses on administration. In the private sector, the private sector is 29%. In the VA, it's about 22%. And that 7 percentage point difference is huge when you're talking about healthcare, which constitutes $4 trillion a year. Again, single-payer reform and not other reforms would allow you to fully capture that administrative savings, devote it towards care. And other reforms, lesser reforms, would either cost more to do the same thing or would do less for the same amount. I'm going to briefly end with pharmaceuticals, and then we'll have time for questions. We know drug prices are very high in the United States, and when the Medicare drug benefit was implemented in 2003, the law explicitly prohibited Medicare from negotiating with drug companies. This changed under the Biden administration with a program that did allow Medicare drug negotiation for 10 drugs at first, and that number will go up. And so you can see for these 10 drugs, these were the percent reductions in list price, and that's a good start. But the problem is much bigger, and particularly as new expensive medications come down the pipeline, drugs like the GLP-1 agonists that really have a huge promise and potential for a very large share of the country. These costs could quite literally be unaffordable for public and private payers. We pay far more for these drugs than other high-income nations, $350 for semaglutide, for instance, monthly cost. And it's lower in other countries, but what I want to point to is that final bar, which is a recent estimate from researchers at what the actual cost-based price is. Like if you got rid of the patent protection, what would it actually cost to produce these drugs? About $5 a month. It's a topic for more discussion, but what that shows is that if we could somehow publicly finance the development of these drugs and didn't have to deal with intellectual property rights, we could provide drugs close to their cost of production. And that is something that's explicitly in PNHP's drug reform proposal, and that I think we need to discuss more. Actually, I had one more brief depressing topic on reproductive health care, and then I'll turn to Trump. This is just an update of the average driving distance to the closest abortion provider before and after Dobbs, before and after Roe v. Wade was overturned. It's shot up, as we know, and it isn't really getting much better, even though there's been some supply increase in states that haven't banned abortion. New evidence is pointing to health harms stemming from this, including a 7% increase in overall infant mortality and a 10% increase in infant mortality with congenital anomalies. And then there's the issue that even before Dobbs, things weren't great. This was a study that looked at catastrophic health expenditures for abortion and related travel expenses and everything else that goes into it, and found that at least in this study, 32% of women who had an abortion had expenses that were greater than 40% of their monthly income, and when they had to travel out of state, 65% reported these expenses. And as people have to travel more for this kind of care, obviously that's going to make things worse. All right, so we'll just close with a brief note on what's coming down the pipeline potentially. We don't know what's going to happen in terms of healthcare financing under Trump. The fact of the matter is, though, there is unified Republican government, and there is the possibility of major legislation, including through reconciliation, which, as you know, it only requires a simple majority in the Senate. Right? So they have the capacity to pass major laws. So what could we see? Well, let's just say that they use sort of regulatory approaches to weaken the ACA. which they did in 2016 to 2019. Well, back then, there was an increase in uninsurance of about 1.6 million, which is the red. And one can estimate from prior studies what that means in terms of how many people die. So 1.6 million people losing coverage probably translates into around 3,000 deaths. Okay, these enhanced premium tax credits that were put into place under the Biden administration as part of the Inflation Reduction Act, those are set to expire next year. The Republicans will probably let them expire. That will mean about 3.8 million increase uninsured, which translates into nearly 8,000 deaths. And if they were to do something like ACA repeal or a huge Medicaid slash, based on the estimates from the last administration, that would mean 22 million uninsured or nearly 50,000 deaths. So these are the kinds of numbers that we can be thinking about. But it's not just healthcare, it's also obviously environment. The last administration shredded more than 100 environmental rules that resulted in worsening pollution. So this is going to be another major issue. But I want to make 2 points to close. First of all, these are very unpopular positions. Regardless of the outcome of the election, if you look at polling, Americans, even Republicans, support Medicare. They support Medicaid. And in fact, a majority of people say they support some form of universal coverage. These rollbacks, these cuts are not popular. This is ground that we can win on, and the Trump administration can be defeated in its efforts to overturn these critical health safety net protections. But I'll just close by saying being only on the defense is invariably a losing battle. To actually move things forward, we need to keep the vision of a true universal health care system in sight and continue to push for that, remaining on the offense and giving people something that is better than the status quo. Because we know that just saying we're going to keep things the same is not going to work, either from a policy perspective, a healthcare perspective, or a political perspective. So thank you.